My respected chairman, co-chairman, moderator and co-moderator and the audience, good afternoon. I am Siddiqur Rahman from Bangladesh. I am sharing my experience about the visual rehabilitation of the keratoconus patients of my experience. I have no financial issues to disclosure. We know the keratoconus patients are the treatment of the keratoconus is a collagen cross-linking for the stability of the disease, the whole process, process of the disease. But for visual rehabilitation, we use contact lens is the preferable. The spectacles sometimes may be tolerable. And Intex is very good option, but the lack of skill and the cost, sometimes we could not afford for the patients. And for Phakic IOL, I used IPCL and ICL both my patients because in Bangladesh ICL was introduced in 2019 and we got the IPCL in 2017. I started from that. And IPCL or ICL, both surgeries can be done in normal the cataract surgery setup, so it is surgeon's comfort, and no maintenance is needful for the patient if it goes well. And both lenses have the wide range of correction opportunities and the different sizes of the lens. So we routinely what we do for a ICL or IPCL surgery, for the keratoconus patient also we do that. We choose the patient according to, especially we choose patient the keratoconus suspect to moderate keratoconus. That means when the spectacle correction is at least 618, then we went for the surgeries. Because the patient expectation, we have to counsel first for this reason. And other procedures are simply what we do for the other surgeries. And the investigations also we do the corneal tomography and the internal ACD. Here is an interesting issue. All the keratoconus patients have the very high internal ACD. But we should check the gonioscope and we will measure the angle because some false in euphoric condition may happen. There is very deep anterochamber and we will got, if it has no problem, you have a very good anterochamber depth, but angle may be narrower. So, but we checked all patients, and if we go for this area, in reading we see the anterochamber depth is 4.25 or something more, but we got the anterochamber angle is 35. Degree, and it is enough. And less than 30 degree, we should not go for this type of surgery. And this is the way we discussed before. The measurement of the white to white is sometimes it may make us some confusion, which should be done or not. But usually we do not face any problem. We only did 11 patients as 17 eye of the keratoconus or keratoconus suspect patients, and visual outcome is very satisfactory with their spectacle, what they have with their spectacle, not contact lens. But all the cases have near to contact lens vision. Their outcome is like that. But no statistical data I am showing here because it could be boring for, and we are running the study, just started a few days back, and this is one of my patient. Just after surgery, just after surgery, he could see all the visions, and they know vision chart is in OT, but a clock, you can see fine. That was the postoperative condition of this patient. The anterochamber depth differs in both eyes. The left eye is worse than the right. Worse, that means the keratoconus is higher. And this anterochamber depth is higher is here also, and so the vault size is higher here also, and all the thing is going well. I thought I started this in Bangladesh first, but later on when I searched for the journals, there are many journals there, and in India, Ritu Arora and the Rohit Shetty, and many surgeons are doing this. So I am not the first one to do the ICL or IPCL in the keratoconus, but in Bangladesh I started this, and I hope it will be a good option. And take-home message is we should investigate the patients and take care of the patients very cautiously. And angle measurement, we should take care of that. And proper counseling and regular follow-up is very important. Nothing problem happened till now, but we have to wait to see for the future. And thank you all for.
Thank you, doctor. I have one question. What is the astigmatism, the spectacle corrected astigmatism you take as, like if it is
I gone through up to six diopter cylinder, and ICL do not make the 6, they do up to 4 diopter cylinder.
Okay.
But IPCL they made it, but not actually fully corrected. We can go.
Okay. See, the problem with these keratoconus is the cylinders are not regular cylinders, irregular cylinders.
Exactly.
So once you correct one axis, they will develop cylinder on the other axis. So you have to counsel them really. But I do have a lot of patients whom I've implanted, but I make sure they are high myopes as well, because if there is a correction of high myopia along with the astigmatism, then they have better benefits. There's no harm in doing in low myopes also, but I feel when it's combined, the keratoconus combined with high myopia, the benefits to the patient
satisfaction is higher.
Patient also is, because the spherical component is corrected, they are much more comfortable. But now with all these mini scleral and scleral lenses which have come, all these patients, I really push them towards the lenses, because the quality of vision that they get with these lenses is amazing. I've had patients who have 3/60 correcting to 6/9. So that also has to be kept in mind.
Thank you, ma'am. Actually, we offer first the mini-scale lenses, but some patients, their lifestyle or their condition is not compatible, then we offer this with a compromise expectation.
Dr. Sujata, what about multiple procedures like topoling PRK followed by an ICL?
I have done that also. I have done that topoling PRK. That's possible in high myopes, where you're not correcting the spherical component, only trying to do an
normalize the surface,
normalizing the cornea. I've done it, but really I am not really for a keratoconus which is beyond -3. I'm not a proponent of doing unless associated with high myopia. I would push them towards more contact lenses. But if the patient is insisting, today is the patient's world. If the patient wants it, I still do it. But definitely, they are not. You don't get the correction that you want. Patients are sometimes happy, very happy. They have -4 cylinder residual and still they are happy. So that is a different part of it. But uncorrected vision you cannot get. What's your?
No, our center is doing that. They have got some initial success after topoling. They have planned a phakic IOL, and some of the patients are doing well.
Yeah. The other problem with the keratoconus is the high rate of rotation, because they have very deep anterior chamber. So that also has to be explained to them. And there's a paper which says you put only don't put a toric lens. You just put only a spherical
toric lens. I put toric lens. All the patients.
There's a paper which says you just put the
and correct the cylinder by glasses.
Correct the cylinder with glasses.
Oh, then the rotation will not happen.
Rotation will not.
It's the right suggestion. Thank you, ma'am. Thank you.
Thank you, Dr. Siddiqur. So the last presentation for the day is by Dr. Doyle Biswas. Is she here now? She's not here. All right, so that will be it for the session.
I think if you have time, Dr. Sujata, you can probably summarize the things and probably we can.
I think today's talk, I think most of it is spoken about phakic intraocular lens. And the most important thing that we found was that white-to-white measurement is key in every case. And also the anterior chamber depth. The cutoff is 2.8. Though, in Caucasian eyes, they have better AC depth. Beyond less than 2.8 is not advisable to go for phakic intraocular lens. And as you start doing it, you will realize how very important it is to do the white-to-white and then plan your case accordingly. If you have 11, they'll give you a 12.6. If you have 11.4 also, they'll give you a 12.6. Because it's not just 1 millimeter above the correction. So it's for you to decide, not the company to decide what is going to be the overall diameter of these lenses. That is one thing. Second thing is, you should keep in mind that very low volts, nowadays there were some presentations which showed even with very low volting, if there is a central flow, there is no cataract. So there is no need to jump in and go and remove these lenses. You can always wait. And other than that, intraocular pressure has to be kept in mind. And normally I admit the patients for 2 hours and just make sure that the pressure is not high, and never close the wound very tight in these patients. I just make it moderate. Even on the table, the pressure will not be more than 20. So that's very important. If you hydrate the wound too much and close it very tight, and then post-operatively, it takes a longer time for them to settle down. And of course, other complications associated with glaucoma and all that. Posterior segment is very important. And make sure that you get a retina surgeon to examine all these high myopes, because some of these lesions we may not pick up because we're not routinely doing indirect. And you have to actually depress and do the retinal this thing. And retinal barrage is important. And in my practice, what we do is we routinely do a specular, and also we do an OCT RNFL. Maybe it helps, it doesn't help, but I mean, just to ease my conscience, I do it.
What's your oldest phakic IOL patient?
2006, I did my first phakic
It's
IOL.
around 16 years.
16 years, yeah.
So what will happen in another 10 years? Will they develop cataract? They will continue to do well? What's your expectation?
I have had only 3 patients who has developed cataract, and I have explanted the lens and put in an intraocular lens. All these years I've never had cataract. So many. That's why the incidence when you read is 4.1%. We don't get that many cataracts at all. I think probably the era before the vaulting, the B4 lenses came, the lenses were made just like intraocular lenses. Those areas, because the touch was more and there was no central hole, we had more cataracts. But nowadays, I think overall all the phakic IOL surgeons will say it's a very safe procedure. And I would like to say, even if patient is -3, patient wants a phakic IOL, I would go and implant a phakic IOL, because the only downside is it's a surgical and you have to take all the precautions needed for surgery. So other than that, there's no contract. I've done.
Why -3? I mean, why that number?
Because it's a refractive procedure, and patient doesn't want to wear glasses or contact lens. So, so when they are not fit for LASIK or even a surface ablation, and patient has good anterior chamber depth, we can do -3 refractive. I have done phakic IOLs.
No. How does the patient decide that he wants an ICL if it is -3?
Patient.
No, it's your call, right? It's your call.
If they are desperate, they'll say, do it somehow. And then they'll say, can I come back after my cornea thickens? Things like that, then we tell them there is an option, but it's a surgical option. You can take a look at the video how it is done, and then the decision is yours. So what is the difference between doing for a -11 and -3? The risk is the same, the age group is the same. So there's no need to deny them of this.
Ma'am, one question. If -3, why not to go for AC?
No, patients who are not eligible for LASIK.
Not eligible for laser correction. What about you, Dr. Tejas? Your threshold for phakic IOL?
Threshold for phakic IOL. Well, so I just wanted to come back to one of the points of 16 years. The vault is going to be very decisive. We have been told so many things. The second was the viscoelastic to be used. If the vault is only, they say half to 1.5. Now half is about 250
Yeah.
microns. Right? Now the lens thickness grows by about 0.01 micron every year. So it's going to grow, and these are the patients who are going to come back with some kind of a altercation. Our threshold for phakic IOL is now becoming very less, because we are using more of surface ablation, and we do up to 470. So our threshold of phakic IOLs has started going up and up. In between, when we were not very reluctant, we were very reluctant to do surface procedures. It was like 5, 6 also. But now anything less than 460 is our first choice of phakic IOL.
No, I'm not. I'm not looking at normal corneas. Corneas which are have keratoconus component or early features of keratoconus, where we cannot do it.
If there is keratoconus component, then even a phakic IOL is also not a good idea, because it's going to be irregular astigmatism.
No, patients who don't have astigmatism.
If I have to answer corneas less than 460, I'm not talking about the refraction. Because anything above 460, we can go ahead and do a PRP.
No, one more narrative, very interesting thing I want to ask you. Like you said, for a person who is ineligible for laser vision correction, you are thinking of, even in low myopes, a phakic IOL.
Yeah.
Why not in a normal cornea? Why not in a person who is probably eligible for laser vision correction? Why not an eyes? Why not a phakic IOL?
The
The
only
why
reason
why
is-
you don't actually prefer it as a primary procedure?
Yeah, the only reason is because it's laser. Patient wants laser. They want something which is not a surgery. So when I tell them there is surgery, then then they come back. Because why can't I do laser for my eyes? So the whole intraocular procedure. It's a surgery. All said and done, it's a surgery.
For a patient who probably doesn't have this mind block, like will there be a day in which probably you will prefer a phakic IOL over laser vision correction because of its
No,
potential reversibility and maybe things get more safer in future?
No, no, sir, no. I have not gone that far. I still prefer.
I'm saying the
last-
future is a more refined laser vision correction or more refined phakic IOL.
A patient with -8 is definitely, or 6, has a lot of magnification, magnification. So I would go ahead with the phakic because the quality of vision with the phakic is 100 times better.
I was coming to that. Yeah, I was coming to that.
Exactly. So I took you there.
So the kind of aberration that we create and the final quality of vision, because we are not using Pellier-Robson chart in our clinics, so we are okay with Snell's acuity, but the patient has its own share of problems. Probably in future, as we go more refined, we'll start looking at more of aberration that we create with laser.
KP, I would say this, everything you'll have to step back a little bit because we have to look at the medico-legal aspects to it. Tomorrow, if something goes wrong, and then you go to the court, when everything was normal, why did you suggest phakic IOL? Whereas in the -3 case, which has a potential keratoconus, then I can say, I gave the choice to the patient to go back to contact lens, they wanted phakic IOL. I will have no word to say in a court when everything is normal and you did a phakic IOL. An intraocular surgery. Patient develops endophthalmitis. See, it's not unheard of. Yes, absolutely, absolutely.
Sir,
Yeah, yeah.
at present, but if you have patients with, let's say, very visual requirement that is much higher than normal, I think we should prefer more of phakic IOLs rather than
yeah,
laser vision
absolutely.
correction because, as sir said, 100 times better vision. Right.
Beyond -8,
Yeah.
it's better to go for
So
phakic.
we've had surgeons that we've implanted, could have done LASIK, but we've implanted phakic IOLs because you need better vision. Clarity of vision is better in phakic IOLs.
Absolutely.
That is the reason, like,
Yeah.
beyond 8 now, we are all preferring.
Yes, absolutely.
Not laser.
Probably that number will come down.
Thank you.